You're watching EASD TV. Now, one of the most exciting features of the new drugs is their potential for action beyond glycemic control. And I know that it's a subject that interests so many of you out there. So I'm delighted to have gathered together the presenters from one of the sessions today about beyond glycemic control. So can I introduce to you, first of all, Katherine Tuttle from Providence Health University of Washington, then Professor André Scheen from the University of Liège, and Professor Norbert Stefan from the University of Tübingen here in Germany. So, who's going to start off on this? Katherine, can I come to you?
Sure.
So, these drugs, their effects beyond glycemic control were not really anticipated, were they?
No, it was really quite a surprise. And we've called them the gift that keeps on giving. And the way they were discovered to protect organs was that in 2008, the U.S. Food and Drug Administration mandated that any new drugs that were approved for glucose control had to be tested for cardiovascular safety because of a history of approving prior drugs and then finding out there were safety concerns later. So they were originally designed to test for cardiovascular safety. But what we learned is not only were they safe, they were highly effective, particularly for heart failure, but they also protected the kidney. And we've now had an explosion of trials, particularly in heart failure and kidney disease, that have really borne out the extraordinary benefits, really beyond what we could have predicted, and beyond established therapies that we had, particularly for heart failure or chronic kidney disease.
So, Professor Scheen, your interest is in the heart and cardiovascular system. So can you summarize for me the trials that have come through on heart protection?
So we have in fact two types of pharmacological classes who have demonstrated their benefits on the cardiovascular system. First, SGLT2 inhibitors, and second, GLP-1 receptor agonists. And the mechanisms are probably different because we have almost the same results on what we have called the MACE 3 points. It is a composite endpoint of cardiovascular disease combining cardiovascular mortality, non-fatal stroke, and non-fatal myocardial infarction. And we compare the results of CVOT, cardiovascular outcome trials, with both types of treatments. We showed almost the same results, a reduction of MACE and also of cardiovascular mortality and also of myocardial infarction, which was almost the same with both SGLT2 inhibitors and GLP-1 receptor agonists. But the major difference was on the heart failure. On the heart failure, the results were almost let's say, mild to moderate with GLP-1 receptor agonists, but there was a very strong effect with SGLT2 inhibitors, suggesting that these compounds have a different mode of action compared to the GLP-1 receptor agonist. So the effect on the heart failure with the SGLT2 inhibitors is probably composite, multifactorial, because at the beginning, we thought that it was very simple. With SGLT2 inhibitors, you promote glucosuria, you have a diuretic osmotic diuresis, sometimes also natriuresis, at least at the beginning. So it was very easy to explain a positive effect on heart failure. But now we are convinced there are multiple effects and also direct effects on the myocardium. The energy metabolism of the myocardium is completely changed with SGLT2 inhibitors. For instance, myocardium used more fat, more free fatty acids compared to glucose, and also some ketone bodies. With SGLT2 inhibitors, we have slight increase in ketone bodies, and these ketone bodies are remarkable fuel for the myocardium. So you increase the potency of the myocardium to have a good health, let's say. And also, there are several factors who have been demonstrated. You have a reduction in inflammation in the myocardium, reduction also of the oxidative stress, and also we have, for instance, increase in erythropoiesis by the kidney, and so you have more red cells, so the oxygenation of the myocardium is also improved. So there is a lot of different effects, and now it is almost impossible to say which one is the more important one.
And let's not leave the liver out of this. Tell us what it does for the liver.
Yes, as diabetologists, we've just discovered during the last years that so many people with diabetes have actually fatty liver. And it's about 70% of patients with diabetes have fatty liver and steatohepatitis, 40% and 20% have fibrosis. So it's a huge problem they've just discovered. And we are very interested in the diabetes field of trying to see whether the SGLT2 inhibitors, but also the GLP-1 receptor agonists, have these additive effects. And the studies that have been published during the recent years, and now actually also during these days, show that indeed there is a protective effect on reducing liver fat and possibly also inflammation with SGLT2 inhibitors and GLP-1 receptor agonists. And these effects are, as we already heard, mediated by increased ketone body secretion, lower inflammation, lower fat that is being brought to the liver. And so these add-on effects we find with SGLT2 inhibitors and GLP-1 receptor agonists are actually now being introduced to treat fatty liver, things that a few years ago nobody ever expected.
And of course, the kidney is also another organ that can be protected. That's your particular specialty, Katherine. Tell us a bit more about the work on kidney.
Well, similar to what you've already heard about the heart and the liver, both GLP-1s and SGLT2 inhibitors have kidney protective effects as well. And they're really quite different, which is great because then we have the opportunity for complementary therapies that we could even use together. With regard to the SGLT2 inhibitors, it's also important to realize that these agents protect the kidney even in people without diabetes. So as we did the chronic kidney disease trials, we progressively included more and more people with non-diabetic forms of chronic kidney disease and people with very low kidney function. And across all levels of kidney function studied, and with and without diabetes, we see this profound 40% reduction in risk of major kidney disease endpoints. So that means a substantial loss of GFR or kidney function, kidney failure, or death due to kidney disease. And this is already on top of the best therapies we had, which of course were good glycaemic and blood pressure control and a renin-angiotensin system inhibitor. And if we walk back to the renin-angiotensin system inhibitor studies, particularly the angiotensin receptor blockers, which were approved more than 20 years ago, the effect sizes were much smaller. They were on the order of risk reductions of
And everybody thought they were wonderful then.
Right, 20%. But on top of those, you get another 40%. We had no benefit on death with ARBs. Now, at least in the DAPA-CKD study, all-cause mortality reduced by 30%.
I mean, they're astonishing.
It's stunning.
So are these the statins of the future? Should we be putting them in the water?
Well, this is a moment, not just in endocrinology or cardiology or hepatology or nephrology. It's a moment in medicine. I do believe it's that transformative. And you could even say for human health, considering how common chronic kidney disease, heart failure, liver disease, and diabetes are, even when they're not all combined in a person with diabetes. So these are really transformative therapies for major public health problems. And I do want to mention the GLP-1s in the kidney. We're still awaiting the large kidney disease outcome trial, but in analyses of secondary outcomes from cardiovascular trials or glucose-lowering trials, everything points in the right direction. Marked reductions in albuminuria and stabilization of GFR. So we're not quite there yet with regard to firm kidney endpoints, but everything points in the right direction.
So I was being a bit facetious there, obviously. Put it in the water. But how are we going to use these drugs in the future? I mean, will it be like, a Swiss Army knife that you start out with a single blade, which is, which is your glucose lowering, but then you add the particular, the blade for the thing that you actually want, or do you give everybody everything? What do you think?
I think we assist to a paradigm shift from glucocentric view to a protection of the organ, a target organ protection, which is remarkable during the last, let's say, 5 years. And one of the problem you mentioned that in every guidelines, international guidelines, ADA, EASD, now there are these two compounds, SGLT2 inhibitors and GLP-1 receptor agonists, are privileged position in patients with, let's say, kidney failure or cardiovascular disease, atherosclerotic cardiovascular disease, and so on. But one of the problems I see is that in clinical practice, the implementation of these compounds are far less what we can expect in high-risk patients. I made a review during the last few months, and less than 30% of the population who should be treated with these compounds are not treated in real life. So I think that the next step is to implement what the guidelines are saying to the clinical practice in order to improve the prognosis of our patients.
So if we start off by trying to get the populations who should get these drugs served, what's the next step? Because what I'm hearing from you is actually they need to be more widely used even than that, possibly even in a healthy population.
Yes, I think for a healthy population or a healthier population at risk, SGLT2 inhibitors and GLP-1 receptor agonists are most probably the drugs for the future. But still, they need to be prescribed with caution in patients, for example, elderly patients, for example, who are on insulin, because if people not experienced in diabetology and endocrinology, for example, give these drugs to people who are already on insulin, if you don't reduce the insulin dose, you may get problems. So I think for a relatively younger and healthier population, they will become like metformin, because they have so many add-on effects in addition to glucose. And then we have the elderly population where we also need to use these drugs, but here we need to be much more cautious and really to keep a diabetologist look, because of the potential of hypoglycemia, particularly if people are already on high doses of insulin.
And we're already seeing a mad dash by people with very low body weights going for these drugs, and they're awash with all over the internet. Is it going to be difficult to get policymakers to take these drugs seriously? Because the worry is that they're beginning to be seen as a kind of lifestyle drug.
I think that's what you see in the lay press, but the scientific evidence is very strong. And I think this is where health policy will be important, is paying upfront for prevention. So that in the long run, hopefully these are a good investment for societies, because we have many less serious complications that are very expensive, like admissions to the hospital for heart failure or treatment with hemodialysis. But we have to have policymakers that will take a longer term view on making the investment up front.
And of course, policymakers are very influenced by what they're reading in the media and what they're even hearing from their friends who've taken these kind of drugs.
Well, I think that's why it's important for us to be advocates.
Yes.
And to really explain the evidence, again, not just with a specialty focus, but from the perspective of the public health.
Yes.
And the broad impact that these agents will have. And in my own field, we've never had therapies that could prevent kidney disease before. If you look at the cardiovascular trials and the glucose-lowering trials, which included a lot of people without kidney disease. If you look at the kidney disease outcomes, they had a 30% reduction in ever developing disease. So if we can move upstream to prevention with these agents, the payoff, certainly for the individual, but even for health economies, would be enormous.
I mean, cardiac failure, heart failure is such a huge problem coming towards us, increasing in numbers all the time. I mean, we've saved people from dying of heart attacks, but only to set them up for heart failure at a later date. So do you see these kind of drugs being given when people have had heart attacks in order to prevent heart failure later on.
Yes, I fully agree that heart failure is a big problem for type 2 diabetes. We have seen remarkable progress by decreasing the cardiovascular disease, for instance, during the last 20 years. But for heart failure, it is a stabilization during the last 10 years. So there is a gap, and we have to focus on this particular complication because the population becomes older and older. I think that the prevalence of heart failure will be a major problem in the population with type 2 diabetes.
And there are not many good drugs for heart failure.
And for heart failure, we have already many good drugs, but as you know, probably there are at least two different types of heart failure. Heart failure with reduced ejection fraction, and for this type of heart failure, which is usually secondary to myocardial infarction, we have already a lot of drugs who have demonstrated a beneficial effect. But for the other type, the heart failure with preserved ejection fraction, which is the majority, in fact, in the obese population with type 2 diabetes, no single drug have already proven its efficacy. And SGLT2 inhibitors were the first one to prove their efficacy in this population, not only in the population with type 2 diabetes, but also what was astonishing, at least at the beginning, in the population without diabetes. We have the same protection in patients with and without diabetes in the population with preserved ejection fraction. So I think that it's the first drug who have demonstrated clearly a beneficial effect. So I think that, and now in the recently published guidelines from the European Society of Cardiology, just published 2 weeks ago, they position the SGLT2 inhibitors as class 1. So it is very high level of recommendation, and now there is a privileged position for these SGLT2 inhibitors. For GLP-1 receptor agonists, concerning the story of heart failure, the evidence is less clear. Probably there is a slight reduction, but it depends on the population, depends on the drug, and so on. So we need more studies in patients treated with SGLT2 with GLP-1 receptor agonist.
It's a hugely exciting time. It does feel like we're on the threshold of something very different.
Well, one of the reasons that we've called these organ protective agents with a glucose lowering side effect is that these agents are protective outside of treatment of diabetes, and the same is true for kidney disease. Heart failure and kidney disease without diabetes can be substantially the progression of disease can be reduced and the serious complications can be reduced. So the effects have to be far beyond the glycaemic effects, because particularly in patients with chronic kidney disease, once the GFR is below 45, there's hardly any glucose lowering activity, but you still get the organ protective effects. So there really is evidence that these are non-glycemic effects of organ protection. And then the preclinical science has borne this out in terms of direct effects on the myocardium and kidney cells that are not the target of the receptor. These are probably off-target effects, but not receptor-mediated effects.
It's fascinating. There's a huge amount of research, obviously, still to be done. But I'm going to ask you to polish your crystal balls. Norbert, where will we be in, say, 5 to 10 years' time?
I think that the weight loss aspect, obesity treatment will be very important for all the diseases that we were talking about, for kidney, the heart, and for the liver. And the GLP-1 receptor agonists and dual agonists and triagonists will be the coming drugs to treat obesity. But as you correctly stated, we always need to have the medical condition in there. So we have the people with obesity that don't have problems, and I think here the aspect of a lifestyle drug is still there, but in the hands of the treating physicians when we diagnose the disease, I think then GLP-1 receptor agonists will be the coming drugs for so many metabolic diseases we touched on. And SGLT2 inhibitors will also, I think, very early will become relevant in the prevention, as we have seen with metformin. And all these studies done with SGLT2 inhibitors with people in pre-diabetes showed a dramatic reduction in incidence of diabetes. So I think that these two drug classes are being much more implemented in the prevention, because here we can reverse diseases and treat them very early.
And it speaks to a change in policy about screening, really, doesn't it? So that the earlier you screen people, or the more universal your screening, the quicker you can get people onto these drugs and perhaps prevent conditions altogether. Where do you see us in 5 to 10 years' time?
I think that we are not at the end of the story. I think it was my last slide. We are not at the end of the story because, for instance, GLP-1 receptor agonist, it is an evolving family. We are moving now from GLP-1 receptor agonist, pure GLP-1 receptor agonist, to dual GIP and GLP-1,
and triple,
and probably also tripled agonist, also involving glucagon. So
that Swiss Army knife is getting so heavy you can hardly hold it.
We have seen remarkable results concerning body weight reduction, for instance, also hemoglobin A1C reduction, more than 2% reduction of hemoglobin A1C. Let's say three quarters of the population were able to reach at least 30% reduction in body weight. So it was very exciting. And also concerning the SGLT2 inhibitors, we have a lot of data on kidney failure, heart failure. But I think that the family is quite, let's say, complete, because the add-on value of SGLT1 plus SGLT2, I think that it is not a remarkable progress. But I think that one of the other progress will be the combination of SGLT2 inhibitors plus GLP-1 or dual GLP-1 GEP, because both the two families have exert direct and indirect positive effects on cardiovascular function or disease, and probably they are also partially different and complementary probably. So we need more data about the dual combination SGLT2 plus GLP-1 receptor agonists in order to improve further improve the prognosis of the patient with cardiovascular disease, and probably also with renal disease.
So probably personalized combinations. Is that what you see happening, Katherine?
Yes, and even now, without fancy biomarkers, we can start to clinically phenotype patients to receive these agents. So someone at higher risk of heart failure, we would use an SGLT2 inhibitor first. Somebody with ASCVD, a GLP-1. Depending on how the GLP-1 trials work out for kidney disease, they could be elevated as well. So we can look at the patient and even now begin to individualize therapy. So I agree with everything that my colleagues said, and I guess the only thing I could add is hearkening back to your comments about implementation now. When we have the most powerful tools ever to save kidneys, hearts, and lives, and hopefully livers, we're still waiting for more evidence on the liver, we really have an obligation to deliver these to the enormous populations of people who could benefit them worldwide.
Yeah. So access and cost is going to be a big issue.
So I do think that there is going to have to be a complementary focus on health policy implementation and public health strategies to reduce the impact of some of the most common and serious conditions that affect populations worldwide.
It's a fascinating story, and I have a feeling it's going to run and run. There's a lot more to be discovered. Well, what an exciting set of insights there, and we really are at a moment in the treatment of diabetes, but also so much more. And there's so much more on EASD TV, so stay with us.